So first of all, good morning, and I should obviously thank you to the team for inviting me. And I guess I should introduce myself for those who don't know who I am. So I'm Dr. Nick Johnson, and I'm here today really in the role as the Mayor for Cambridgeshire and Peterborough Combined Authority. Just to reassure you, I am also still a practicing children's doctor. Only this Tuesday I was at Hinchinbrook Hospital, and that's where I do a weekly clinic. Now it might be obvious, but I've been a medic a good while now, sort of a good while longer than being a mayor. And in many ways, I think I wanted to be the mayor because I was a doctor. Because of all the things that I was having to deal with for those children, and still do, that I see in the families, there was a sense of frustration. Treating the patients with without being able to seemingly solve the problems that was making them ill in the first place. So you can prescribe inhalers, but then you're actually powerless on the air quality around where they live. Diagnosing chest infections, but unable to do anything about damp and mould in their homes. So in many cases, it felt more and more like I just couldn't do enough, and it didn't sit right with me. So I'm sure, and I hope, you will be mentioning the names of the likes of Sir Michael Marmot. It's at a sort of later stage that and his work and that all that work on the wider social determinants of health that need to kind of understand how they fundamentally change, and how if we understand how they then lead into health inequalities, which the slides very eloquently demonstrated. So when I got the opportunity to, I spoke last year at a similar conference, but I have to say, John, I was a bit like you. Public health, precision medicine, they almost seem two different ends of the spectrum. Precision, very targeted, when we talk about public. So I'm going to be hanging around for a little while to try and understand where we are moving towards. As we all clearly appreciate, the consequences of unequal health outcomes aren't just profoundly felt by those immediately affected. They go well beyond the individual, ripping out households, communities, towns, cities, regions, even nations. I travel around Cambridgeshire and Peterborough, and I know where all the poverty is. It's in this city, it's in Cambridgeshire. Don't kid yourself, you might be in Cambridge City, but there's problems of real pockets of deprivation here, and it goes with health inequalities. That can have huge, significant impacts on society, socially and economically. And as the Mayor, it's the economy, however, that I'm tasked with supporting. It kind of goes back to those missions that we've just been alluded to. And as economies go, it's certainly true that Cambridge and Peterborough present some uncommon complexities and unwelcome contradictions. Crudely, for everything here considered world-class or leading edge, and that can be you as individuals, for every successful spin-out, every unicorn, ours is also a region also having to contend with multiple layers of really very entrenched, very pronounced poverty and deprivation. So for me as Mayor, that's a dual reality, a vast divide, layering bare the responsibility of the state and the urgency with which we need to intervene. And I, again, would like to echo in the previous talk an acknowledgement that having come into government, they've made a lot of state on how they want to do this through a mission-driven government and 10-year growth plans. And that's where the combined authority comes in. For those of you who haven't taken an interest in local government, devolution is where it's at. I'm a local politician, but within 4 days of the general election, myself, Andy Burnham, Sadiq Khan were invited down, and we're tasked with helping drive the economy to help solve some of these problems. So what are we doing? Well, for example, you might have seen that since the general election, yes, we've got local growth plans, looking at what our region does best. And it's in this room. There's innovation, there's also knowledge. But it's not always how you put those two together in challenging public health, and it's about not just about gross domestic product. Economic growth, when pursued intelligently and compassionately, I'll come back to that word, with a laser-like focus on reducing inequalities, can, should, and must significantly improve public health. That's why I'm here. To achieve these goals, we must consider the structural changes needed to support our efforts and question them and embrace new technology. We, in concert with you, our partners, are uniquely positioned to understand and address the specific needs of our communities. We can ensure that local solutions are tailored to local problems, leading to more effective and sustainable outcomes. Anybody who's ever seen me speak before, they'll know what I'm going to talk about next. One such readily deliverable, practical intervention revolves around better public transport, not least in the form of a ubiquitous, sustainable, reliable bus service. And as I have the pleasure of being in a room where there are, I would say, generally more younger people than I'm used to, I would like to know how many of you have already got your Tiger card. So if you're under 25 and use buses, you should be using your Tiger card, because that's part of the combined authority. So anybody under 25, you can check it up, and your fare, if you've got a bus here today, if you paid £2, you didn't have to, it's £1. That's what it is: sustainability, affordability. Rural and semi-rural isolation are big issues for us, for the person and for the multitude of missed opportunities. When you have rural isolation, you have challenges around connectivity, and if you're not connected, you miss out on opportunities of education, employment, or just going out and socialising. So a chance to socialise, very important, active, and to be immersed in the wealth of cultural offerings. And there's a lot of them around here in Cambridgeshire. To be somewhere new and to be someone new, that's what connectivity can mean. So what we have to do, and that's local government working with all partners, is to work consistently, collectively, in the pursuit of much, much better civic infrastructure, of which public transport is up there, with good quality, affordable housing, and we can begin to bridge gaps of inequality and challenge the inequality of life and life chances. So let me stress, though the begin part of what I've just said, not for 1 minute do I think that public health solutions lie solely in the new stuff, be they buses, houses or jobs. That's why I'm here today, because I'm sure there's innovation here that can help us drive that. It's not just about smoking cessation, it's about targeting those ideas. We have to understand them first, but then we need to build on it. As I see it, we need a fundamental mindset shift. From frontline public servants to the most senior members of governments to solve our public health crises. We need compassion, that word again, empathy, and a willingness to acknowledge that many of our most treasured institutions need to change. And I do have my NHS badge, but it has to change if we are to change the fortunes of not only those most in need, but also those of our collective selves. So, at the start, John, when you introduced it, you said, I'm not quite sure what this all means. I'm looking forward to hearing what the discussions, what the presentations bring to that sort of challenge. We know what it is. If precision medicine is a part of dealing with health inequalities, I'm all signed up for it. But if I can leave with one thought. I got elected, some would say surprisingly, in Cambridgeshire as a Labour mayor. Things are changing around here politically, of course. But one of the things I said in what I campaigned about, I had these values of 3 C's. Compassion, cooperation, and then you deliver for a community. I would challenge you all, for those who are coming up with new ideas, and for those who take public health seriously, always remember 3 C's. The 3 C's of compassion, because if you have compassion and you care about making differences to society as a whole, which I know you will, because you signed up to it and you're at this conference, if you show compassion, you get the cooperation from the population. They want to work with you. They have the same aspirations as you. Compassion, you get the cooperation, and then you really do deliver for the community. And that doesn't matter if you're a politician, if you're a children's doctor, if you're in the public health sector or the private sector. That's what our society needs, 3 C's. Compassion, cooperation and community. And I hope this conference today is going to be part of that change. Thank you.
Good morning, everyone, and I'd just like to add my thanks to you all for coming along this morning. My name's Andrew Flewitt. I co-chair the Precision Health Initiative here in Cambridge, a role I've come into rather by accident. My background is an electrical engineer. I'm not a sort of clinical person at all. But actually what really makes me want to be in this space is when you think of the UK population, it is made of 68 million individual people. They are all unique. And they all have their own particular needs when it comes to health and well-being, if we're going to really tackle some of those inequalities that we saw, for example, in Aliko's talk, or in sort of Nick's description of society here in this sort of Cambridge and Peterborough region, which is just pretty typical actually of the nation as a whole. So we're going to start unpacking that in this first session. We're going to focus on early disease detection, and we've got 3 speakers sort of covering very different parts of that. We're covering the full age range from sort of very early childhood through to sort of older years, and we're covering 3 different sort of types of disease as well. So I'm delighted that our first speaker is Professor Nora Pashian, who is in the Department of Public Health and Primary Care, where she's Professor of Epidemiology of Ageing and co-director of the Cambridge Public Health. Nora.
Thank you very much, and it's a pleasure to be here and very good to see you. Thanks for coming. So I will give the first example of precision public health, which is precision cancer screening. In 10 minutes, I will introduce what it is, why do we need a shift, and what is precision, or I call risk stratified cancer screening. Now, we do use age and sex to decide who to offer to screening. Right? For example, I will take breast cancer. We invite to screening women age 50 to 70 every 3 years. And women age 50 to 70, they represent around 25% of women population in the UK. And in this age group, almost half of the breast cancer cases occur, but the remaining half are in women who are not invited to screening. Women of black ethnicity, they have a higher chance, 40% higher chance of dying from breast cancer compared to women of white ethnicity. And this is they are more likely to develop to have a cancer which is aggressive type of cancer, which is hormone receptor or negative or triple negative breast cancer. These are that grow faster and often not picked up by the screening program. They occur in between 2 screening rounds, or call them interval cancers. What the US did recently, they come up with a recommendation of saying, screen all women from age 40 every other year. And this is to reduce disparities. But that's not the solution, because the more you screen, also you're going to pick up some of the cancers that don't need to be picked up, such as the carcinoma in situ, and they are the major contributor to overdiagnosis. So what do we need is a different way of screening, in a way to identify the relevant cancers earlier, but at the same time without causing unnecessary harms. What is risk stratified screening? So let's start. We start with our population. And here I give the different colors represent the 10-year absolute risk of having breast cancer. And these are calculated based on population in Canada. So what we do, we have your population, and then you do your risk assessment on everyone. And why is it important? Because let's look into women who are age 60. They are, an average woman of 60 would have a 10-year risk of having breast cancer of 3 to 4%, whereas if you look at the age 60, some of women will have a risk as less than 1%, and others will have as risk of 10%. So there is variation in the population. Now, why do we do the risk assessment? The purpose is to stratify the population, to bring them into different risk categories, and then to tailor our screening differently to each risk group, which is by changing the age range, the frequency, or the modality of the screening. But of course, to do so, there are multiple questions yet we're working on. So which is, which risk factors should be included in the risk assessment? When should we start doing the risk assessment? Would it be one-off or needs to be repeated? And how to organize a collection of risk information at population level. And then the risk categories, how many should we have, how many which is feasible, how to set the threshold. And the risk way of screening is which intervention, to which group, and how to generate the evidence. Do we need to have a randomized controlled trials? And then why do we do this? Therefore, very important, why we are aiming, what are the outcomes we are aiming to optimize? So all these questions, which, what, how, why, will define our risk, stratified program. And this in itself will determine whether it's going to be effective in reducing cancer deaths, whether it will be cost effective, whether it will be feasible to run on a population level, whether it will be acceptable to the users and to the providers, and whether it can be delivered equitably. Now, of course, we need to remember that all this also, other than the how and why that are affected by other factors. Of course, we need the research evidence. Of course, there are the resources, whether it's a manpower, financial, technological. Also, we need to take into account the societal, what are our values, our preferences, and then take account of the healthcare system, whether it's ready, whether people are willing and able, and also how open it is to learning, which is trying and then try to improve. I'll give you an example, a couple of examples. Here is a breast cancer screening. We've looked into a risk-stratified screening by varying different age and start age and the frequency of screening, and we've considered 3 risk categories: 10-year risk based on age, polygenic risk score, and risk factors for breast cancer like lifestyle factors and hormonal factors. And this is based on using data which exists, has the risk information. We linked it to the national screening program data, and then we built our model. So by combining this, we studied more than 550,000 scenarios. And we found that there are scenarios that you could do better than the current existing program. You could have less screening episodes, at the same time having less overdiagnosis, less of the interval cancers, and also you could have more cancer deaths avoided and more life years gained. And this is by changing the frequency and the start age of screening. Looking into prostate cancer, we don't have a screening program, and that's because there is a high overdiagnosis. Again, looking into model-based estimation, we said, okay, let's look into what will be the outcome if you screen on men, or if you follow them over until age 90. We have different scenarios. One is no screening. The other one is supposedly we have a screening program where men are invited every 4 years from age 50 to 69, and using the blood test PSA test. And the third was a risk-based approach. And the risk-based, we said, okay, we set a risk threshold, and we invite men at the age when they reach this risk threshold. And again, we invite them until age 69 every 4 years. So we've taken the 10-year absolute risk based on the polygenic risk score and age. And for different risk threshold, we've estimated the outcomes. So first of all, we're looking into the cost effectiveness. In order to compare the different scenarios, we've looked into the net monetary benefit, which is combining the cost and the out benefits, or the quality adjusted life years, in a single value. Now, we've taken, for example, take a look at the dark line, which is the nice cutoff point of willingness to pay of £20,000 per quality adjusted life years. So we see that the lowest monetary value we see with the age-based screening. And if you look into no screening, actually it's more cost effective than having an age-based screening. Now, if we have a risk-based screening, and if we start from a cutoff point of 10-year risk of 3.5%, then it's going to be more cost effective than not screening or an age-based screening. And this will continue. Then we see an improvement in net monetary benefit, and then we reach a plateau at the cutoff point of 10-year risk 7.5%. And therefore, how to decide which cutoff point to use for screening? We also look into the benefits, how much cancer deaths you avoid, and how much you have overdiagnosis, the harms. So, and of course, these are how much overdiagnosis you would reduce by having to put your threshold, and also how much cancer deaths you would avoid. So just to take an example of the 3.5%, here you would be inviting only 50% of men 55 to 69 years, and you're going to reduce 16% of the prostate cancer death, and also have it compared to no screening, and if you would reduce 26% of overdiagnosis if you had an age-based screening. Now all this led into this scenario has been now started a trial, the Transform randomized trial for prostate cancer is one of the arms we're going to study. Now putting all this together, therefore designing the program, It's more than the evidence. Of course, you need also to consider what are how you want to inform, how to do communication, how to engage the public, and how to put the policies to protection from confidentiality, and also how to train the workforce and how to have care pathways and all this. Therefore, there are multiple jigsaw puzzle pieces, and we need to look at that as a system. But the challenge here is it's not a two-dimensional puzzle. It's like a Rubik cubic. This is the one. So if you change one bit of this of each components, you will have a trouble you have to adjust. And this is recently, a couple of weeks ago, we were in Canada, we ran a workshop on how to bring these jigsaw puzzles together. So to end up to say, therefore, one size does not fit all, and risk-stratified screening could improve the efficiency of the program. We need to have consideration of implementation, and the question is, when is the right time? Thank you.
Thank you very much, Nora. Our second speaker in this session is Dr. Coco Newton, and she is a neuroscientist specialising in cognitive assessment for early Alzheimer's detection, and she's based in the Department of Engineering.
Thank you very much. It's really nice to be back at Robinson. It's where I did my PhD, so I'm enjoying the reminiscing. So, how do I toggle the screen? Oh, it's there, sorry. So I am a cognitive neuroscientist by training. That's what I did my PhD in. But then by nature of realizing that science doesn't make it out of academia unless you do something about it, led me into the field of systems engineering. And it's actually quite remarkable how similar the structure and themes of my talk are to the previous one we just heard, but now in the context of dementia. So I have 3 key takeaways. The first one is a sort of context setting of catching everyone up in the room about what is the complexity of dementia and why do we need earlier diagnosis. The second point is this idea that systems thinking and systems approaches might offer a solution. And the third idea is, well, how do you understand where those interventions in the system need to be made? And something like patient mapping, patient journey mapping, which is from the fields of design and design thinking, might offer a solution there as well. So, on to the first one. So, dementia diseases really, all they do is they cause premature cell death, which means that everything becomes accelerated and worsened over time. And I think the real shocking thing is that we've had some newly licensed treatments, they're not the solution. They might slow the disease down, but it's suggestive that we're now entering an era where we might one day have a treatment for dementia. But current estimates are that if that treatment was made available on the NHS tomorrow, only 2% of patients would be able to access it. So there's a systemic problem in terms of detecting the right people for it. There's also this public health concern that we think around half of cases might be preventable. And within all of this, it's fast becoming the leading cause of death in the UK, so the urgency is there. And when we look at a sort of model of, well, what actually is dementia, over the life course, you've got people that never develop biomarkers for a dementia disease. You've got people that do develop the biomarkers for a dementia disease, but they won't ever cross to the threshold of having dementia. And then you have a subgroup of those people with biomarkers that progress along the dotted line, who will eventually go to a clinical diagnosis of dementia. And why people started to go up the dotted line or not is still up for debate. It might be things like cognitive reserve, it might be other preventative factors, but the point is that people are detected at that dementia threshold based on traditional cognitive tests aiming to detect dementia. But we now know that those dementia diseases start in the brain about 20 to 30 years prior to that, and so it begs the question, well, should we be detecting people at that inflection point when we might have a chance of stopping the disease before it develops into dementia? And we do actually have diagnostics capable of that, and that's where I'm coming from, and that's where my PhD was. So if the status quo is a sort of conventional pen and paper cognitive test that you do in your GP when you present with cognitive concerns, and that will only really detect you if you're right at the threshold of dementia. But in my PhD, we showed that there are digital cognitive assessments that you can do that target slightly different behaviors in a more precise way that could potentially detect cognitive changes pre-dementia, maybe 5 to 10 years. But we also have wearables emerging, and there's another talk later today about that the idea that if you longitudinally track people's behavior over time at home, you can get even more sensitive readouts of behavioral change that are indicative of potentially an early manifestation of disease. And finally, we have these ongoing clinical trials of blood tests that could, in theory, pick up the development of that biomarker in individuals as early as their 50s and 60s. But we have these diagnostic technologies, we have the idea that we need to diagnose people earlier, but we have no consensus on what good looks like for this. So where and when should that diagnostic journey start? Should it start by the doctor through screening, or should it start by the patient through presentation to clinical services? What is the ideal diagnostic journey, and is ideal the same for everyone? And these are really hard questions to answer. And ultimately what we're asking ourselves is, what is the ideal patient journey of the future, given the current constraints of how health and care systems work? Which leads me to this field of systems approaches and systems engineering, and how lending, or sort of adopting that form of thinking might help us separate out these questions and come up with ways to answer them. So I work with John Clarkson, who was one of the developers of something called Engineering Better Care. So this is a framework of how you can take principles from systems engineering and apply them to healthcare to think about health in a more systematic way. And this is what it looks like in practice. You have 4 key perspectives. So you have the people element of healthcare. Who uses the system? Where is the system, and what affects the system? You've got the system view of the system. So a system is really just a collection of elements that are linked together, and then something emerges through the interaction of those elements that you can't really understand from just looking at the elements in isolation. So what are those elements? How do we measure them? How are they performing? The design perspective is really thinking about, well, what are the needs of the people in the system, that sort of user-centered perspective of healthcare. How well are we meeting the needs of those people, and how can we do better? And finally, the risk perspective of healthcare. So not only of what can go wrong in healthcare, but what are we currently doing well that we need to champion and do more of? And how can we improve those things? And then those 4 perspectives are wrapped up in a project management set of questions around constantly asking yourself as a team, what is the problem we're solving? What does good look like? What is the vision we're aiming for? And who should be involved with us along the way? And the idea is that you're, in essence, constantly juggling these different perspectives on healthcare. So in practice, that becomes a wheel of questions that you sort of approach iteratively. So you go around the wheel, you collect evidence to start answering those questions, and every time you go around the wheel, you hone in a little bit more on understanding what good looks like and how you can get there, so you can sustain a version of the healthcare system that you're trying to change in a better way. So what does that look like in the context of dementia? So honing in on sort of the earlier questions of, well, what is the problem that we're trying to solve in dementia? And earlier I mentioned that we have these new diagnostic technologies available. For example, the one I did in my PhD, which is this digital tablet here. So how do we get these into healthcare? Well, first you have to ask yourself, okay, well, it's clearly a GP context system. That's where the system is. What affects the system? You can start to map out how a GP decision-making process works by thinking about what are the events that a GP has to go through, what are the events that a patient has to go through, how do they interact, where does the cognitive assessment step fit into that? And then you move around, and then you start asking yourself, well, if you are trying to get a new cognitive test into the GP surgeries, into primary care, who should be involved in this process? So we've put together a team composed of multiple different stakeholders and experts, but the point is not to understand in detail what everyone does, but that you need a very diverse team who has diverse perspectives to bring together the change that you're looking for. And then you move on to the question of, how do we perform now? And there's a lot of ways in you can answer that question. You could look at metrics of patient flow. You could look at sort of health economics, but I'm advocating for the idea of looking at the patient perspective, which brings me to this final section of my talk of patient journey mapping, and using this potentially as a tool to understand where in the context of a dementia system you should start to make these improvement projects. So in brief, there are lots of people involved in the journey of going through a dementia diagnosis. And of course, one journey is not the same as another journey. But there are commonalities, and when you start to zoom out at a population and community level perspective, you realise that there might be some commonalities and ways to investigate that. And in particular, the way you can do that is through patient online stories. So the Alzheimer's Society Forum has over 2 million posts of people living with dementia and their carers asking for advice on how do I deal with this? What do I do? And this is one example post here, which is really quite emotionally jarring to read it. But we have 2 million of such posts, and that we need to understand people's perspectives at a community level without overburdening patients by constantly asking them for their experience. So we did a study where we data mined all of the text from this forum in permission with the forum itself. And then we used machine learning to cluster different themes that were emerging out of what people are talking about in the forum. And together with a team of designers and human-computer interaction researchers, we were able to sort of begin to map out all of these different factors to the care pathway that you can see at the top. And the point here is you can see the map in more detail by the QR code at the bottom. But what I just want to bring to attention is I talked at the start of this talk about the idea that we need new cognitive tests for diagnosing, but that's just one tiny little section in a vast sea of different problems and needs and barriers that people are describing in the patient journey. And then it becomes a question, well, what is the right problem to solve? When we look at the care pathway, all of the different problems that drop out of it are all in their own right. They all deserve their own systems improvement project. And then the other element is that these problems are probably interconnected, but if we don't zoom out and look at them as a whole, you can't begin to make the links together. And there might be that solving one problem solves other problems, or it might be that you can't solve one problem until you solve another problem over here. And so my take on how you can make public health more precise is zooming out to realize what the extent of variation is before you can start zooming in. And that by combining the perspective of public health with medicine, with participatory research and mapping out these factors, you can begin to muddle your way from an unclear idea of how the system works into something that is measurably better. So thank you very much for your time.
Thank you very much, Coco. I'm going to keep us moving through the 3 talks, and we'll do sort of questions and discussion at the end. So the third speaker in this session is Dr. Anna Moore, who is Assistant Professor in Child Psychiatry and Medical Informatics. And she's going to be taking us to those very early years of identifying mental health problems in children.
Thank you. So I'm a child psychiatrist, and I'm particularly interested in the mental health crisis that we have in our children. So 20% of children and young people have got a diagnosable mental health problem that would benefit from an evidence-based intervention according to NICE guidelines. But we're reliant on a system that is based in hospitals and with specialists for both identification, assessment and management. And that's a system that we all know is failing. And as a result of that, we're now in the situation where 70% of young people do not get access to mental health support within a year. So I'm going to be talking today about how we might use data and digital to think about redesigning that system for care, how we can use precision health and the infrastructure that's needed to support that, and also thinking about how we can move that system for assessment and treatment into the community so that we can address some of the capacity issues which many of us are really painfully aware of. So if we look on the right-hand side, we can see how we can look at a population perspective of how we might be able to understand this problem in terms of data. So 20% of the young people have got a diagnosable problem. And we've got a real issue with unwarranted variation in identification. So many of the people who identify problems in the community know children well but don't have the skill set to be able to identify them. And so that means that when we look at the referrals into CAMS, which is Child and Adolescent Mental Health Services, we've got this mismatch between those who need help and those who get referred into services. As I described, we've got a real problem with capacity in our services. So if we look at the referral rates on the left-hand side, figures are far too small, but they've doubled between April 2019 and more recently in 22. But our funding for CAMHS hasn't. So the national budget for child mental health services is the same as the turnover for UCLH, so one hospital in London. But not only that, we don't have the people to meet those needs, so about 20 to 25% of posts nationally in CAMHS are unfilled. So even if we chuck money at it at the moment, we can't rapidly solve that problem. And that means that the children who are getting help are not those who need it and not necessarily those who get it. So how can we find the children who we're missing, many of which are the most vulnerable and most in need, and how can we create more sense to this system? So there's different places in our community systems which we can look to find these children. So one is social care. So many of these children, in fact most of these children, need help. Some are referred and very few actually get help. And equally, if we look at our acute systems, we know that those who are suffering from physical health problems, about 30 to 40% of children in outpatient paediatric systems are actually there because of an undiagnosable mental health problem, and that's their primary disease, a problem. And they're having multiple tests in acute systems, which is causing huge waiting lists in paediatrics, but it also means that their well-being and their mental health needs are not being met. If we look at it from the other perspective, those with a physical health problem, many have got comorbid mental health problems which we don't identify, so about 25 to 40% are not identified, and this makes it harder to treat our physical health problems. So we need to rationalise this system, and data is a way that we can approach this. But the one thing that we can take home from all of this, if we think about where the data for all of those children sits, it doesn't sit in one place. There's not one place where we can identify these children or understand them. And so what we're trying to do firstly is to improve the capacity for child mental health services by moving care into the community and moving the burden of diagnosis and identification and much of the management into the community, and then trying to create systems that enable us to get to the point where those who need help in specialist systems are those who are getting it. So there's lots of ways in which data could be used for a clinical system. So we've talked a little bit about population stratification, early identification, but also critically, everyone says to me, but so what? You're going to identify all these kids. You don't have a system that can meet that demand. It's true, we don't. However, we're not utilising the digital and the community systems that we could very helpfully use to meet a lot of the demand and the requirements of those children's. Can we use digital to signpost people into those systems more effectively? Can we avoid harm, and can we avoid relapse? So how feasible is it to use AI? We're at the point now where we have systematic reviews of algorithms that can identify mental health effectively, more effectively in fact than clinicians can. We're able to identify the difference between placebo and depression. We're using social media and other types of data to be able to help us characterise and identify problems. And increasingly, we're using electronic health records. But there's a big problem with these systems, in that we have either two outcomes: either a very effective model that can accurately identify people with mental health problems, but we don't have access to any of that data, and it is a real diagnostic load on the system. Or if we try and use data that is readily available, we cannot get models which are precise enough. So we have this real implementation chasm. It's not a gap, it's a chasm. And less than 0.5% of algorithms ever get anywhere near a clinical system. So in order to address this, we need real-life integrated data in representative data sets. So it needs to include a range of factors. So on the right here is an example of some. So it needs to include social, environmental, biomarker, clinical data. But it also needs to be representative. So we cannot be building these models in cohorts that are recruited into research studies only, because as we know, predominantly those cohorts involve posh, rich white people. So there's lots and lots of children of professors and doctors in those cohorts. And from a data perspective, if we're building data-driven solutions, it's particularly important that we have representative cohorts that are population level, so that we're not introducing bias with our AI. But finally, we also need this data to be data that's available in clinical systems now, so that we are able to address this implementation challenge and build tools that can be used in clinical systems and don't ever never reach the clinical systems. So we're addressing this by building CADRA, which is a child and adolescent data resource. So we're building it in Cambridge, but now in collaboration with the Mental Health Mission, we're disseminating it nationally. And each CADRA is a regional, whole population data cells that brings together data from all of the agencies within a region. So in our case, it's social care, that includes early help, looked after children, social care, health, so community, acute, mental health, education data, and in the future we'll bring in biomarker and genetic data. And it brings it together into a shared data environment, which means that other people, academics and innovators, can use this data to build data-driven tools and to gather insights into children, as well as our research programme. And importantly, this data can be used for quality improvement and for population commissioning. So we've created the most comprehensive data set relating to children in Cambridge to date. This isn't in terms of number, but in terms of depth of data. And we also have a framework of risk factors that enable us to understand how we might best predict mental health. And these risk factors, of which there's nearly 300, are set into 8 domains and which are measurable and can be rapidly integrated into AI models within CADRA. So, although it's great that we can do this in Cambridge, Cambridge isn't very representative, and also mental health, a lot of the severe mental health outcomes that we're looking to avoid, for example, suicide, psychosis, are really rare in individual cities, so we need large sample sizes. As a result of that, we're working with a company, a startup here in Cambridge, to enable privacy-preserving federated analytics between these CADRAs. And this gives us access to around 3 million young people. So we will get to a position where we are able to measure risk factors that are predictive as well as outcomes at a geographical level. So this is not our data, it's COPD, it's the internet, but we're looking to replicate this with mental health and the risk factors for paediatric disease. Through our work with the NIH, our bioresource, we're critically recruiting the first cohort of the whole population cohort of young people who are contributing their data to genetics and also consenting to link that to their health, education, social care data. We're recruiting via an online, it's the first cohort like this which is being recruited predominantly online. So we communicate with parents and carers only, not to children directly, who talk about the study with their children, can consent via post and provide a sample by post. We've been running for a year and we've secured about 2,500 samples now and over 10,000 consents, and we're looking to create a cohort of about 12,000. So it's absolutely critical that these data-driven approaches must go beyond just a bit of external validation. Like, we're increasing the understanding that if we're building these tools and they're tools that are going to be usable, we must be thinking about evaluating them for dissemination. And so on the right here you can see some of the principles that we're using to think about ensuring that we're building responsible AI tools. PPI is absolutely critical to this, and co-creation. So Jessica, who's here, leads our PPI programme, which is called Caring. And this is a community of young people who've been working with to build CADRA and who will co-design these tools with, but also have now created a community who are keen to support research, paediatric data-focused research. And so if there's any academics wanting to be able to access a diverse community of young people and carers and guardians who'd like to work on this area, please get in touch. So we propose that we're now bringing together the building blocks that enable us to move towards making this a reality. So we're building the data system, we're bringing the biomarkers in, and we have the PPI and the patient and public involvement programme, which together means that we can build Timely, which is our early intervention pathway. We're really excited to be a partner with the Children's Hospital, so we also have the opportunity for this digital system to be embedded in that clinical system and to build pathways and evaluate them within the novel system that's being built there. So thank you very much.